nothing to disclose. And so I really wanted to stimulate a broader approach to measuring health, and some of it is quality of life construct and definitions. And I want people to understand the perspectives of the preemies. Since I'm talking only about preemies, but we did have control group who also participated in the assessment. So I want people to understand the differences in perspective of disability and quality of life between premature teens, adults, parents, and health professionals, and to appreciate and celebrate the voices of adults born preterm who are now in their fourth decade. So we all know how to measure health. It's an objective diagnosis, for example, cerebral palsy or blindness. This is what a child has, and we're very comfortable with this. Function is something that wasn't given much attention, but function is very important because, as you know, one cerebral palsy is not similar to the other cerebral palsy. So here it's what a child can do. And quality of life is patients' own valuation and subjective ratings of their perceptions of their symptoms, functions, and values. So this is what a child feels. And these three are very different and not interchangeable. So usually for decades, and including me, we used to report the outcome with neurological sequelae. And we had many tests which were designed by health professionals. So you got a score on about a dozen tests, but it didn't really give you the overall picture of a true child, because we were comparing one dimension at a time without consideration of parental perspectives or the child's perspective. So there's been a shift in thinking. Measures of diseases status are insufficient now to capture the personal burden of illness. Other factors must be considered, such as pain, apprehension, anxiety, emotion, and ability to fulfill personal roles. So it is very important that we determine not only what the illness is, but the impact of the illness on daily life of the individual and their parents. Life is very broadly. Most of the politicians who tend to say they'll improve your quality of life, and Italian pasta here is advertised as improving your quality of life. But quality of life is a very multi-dimensional construct, and it's influenced by one's own personal values, and health is only one of these factors. There are other factors such as political, religious, social, emotional, environmental, etc. So it is subjective well-being considering many factors into consideration. So it's also multidimensional because it looks at all different aspects. It's subjective because it is your own feelings that are projected, and therefore it's personalized, and it includes both positive and negative facets of life.
We can't hear you.
You're muted somehow. You see, I see that. I don't think I can unmute you.
Can you hear me now?
Yes, yes.
Oh, sure. You didn't hear me at all before?
Just the last couple of minutes.
Oh, okay. All right. So sorry. So health-related quality of life focuses only those aspects that are related to health. Of course, you cannot separate the other factors, but still, because quality of life is such a broad issue, it's very difficult to measure. And health-related quality of life is also not easy. But I think it's very important. So it implicitly reflects the personal valuation of the individual, and it may not be directly observable by a third party. And they're unrelated to disease state or severity. For example, two people who, say, for example, have visual problems will rate their quality of life very differently. Okay, now it won't let me proceed. Could you, Sabine, forward the slides?
I would have to share what I have. I can do that. Okay, I'm sharing then. Hold on.
I don't know why it won't let me forward it now.
No, we usually don't. Can you see?
I can see you.
Okay, can you see the slides? I'm sharing.
Yes, we do.
So are you going to?
I can advance them if you just tell me when to advance.
Just go a couple of slides forward.
Sabina, can you use presentation mode so we get the full?
Well, it's not. It's an Adobe document.
Oh, okay.
Where do you want me to go? Like this is.
Can I try again and start again? And, yeah.
I'm sorry. This.
Okay.
Let me unshare.
Okay.
Or if you take over.
I'm back. So the health-related quality of life is.
Do you want me to stop sharing then? Do you want to try to pull up your slides or?
Yeah, I'm pulling my slides. Can you see that?
No, I have to stop sharing. Now you have to share. You have to share again.
Start again. No, it's still not showing up the way it should. I give up.
I'm sorry, we usually don't have that much trouble. Do you want me to pull it up on the other document again? Then
I'm going to try one more time. No, it's not working.
Okay, I'm going to share then and pull up the other document, okay?
So I'll stop sharing?
I think I took over. So can you see the slide that I just pulled up?
Yeah.
Or it's still objectives?
It's a small version. I don't know if you can see it better in your side.
Can you guys see the slides? What I pulled up?
Yes, we can.
It's okay?
Yeah.
Okay.
Yes, we can see.
Okay.
Could you proceed a few more slides forward?
Tell me how many.
More. Next. 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 Okay. So I was saying that I like this definition by Schipper, that it's an attempt to quantify in scientifically analyzable terms the net consequences of disease and treatment on the patient's perception to live a useful and fulfilling life. So it is this defining characteristics that distinguishes health-related quality of life from other measures of health status and functional status. Next. So after I was doing follow-up until school age, I decided that this was too pessimistic a picture on focusing only on disabilities. So in the early 90s, I decided to say, why don't we ask the children? So we did this in two ways. We measured their quality of life at teenage and then again at young adulthood. And secondly, we obtained narrative stories while they were in their 30s. And we also obtained quality of life ratings on hypothetical health states from parents and health professionals. Next slide. So this is an econometric approach, and it's a very narrow approach. And this is chance board, or it's a lottery approach. And you can see that on this upper half, you have the 90% chance of perfect health and a 10% chance of death. And in the lower portion, you see the child's original health state. So they're given the option of having 100% of their health state versus perfect health or death. And the probabilities are varied across the board until they are equivalent, and then you get a score. Can you hear me now? Okay.
I can hear you, yeah.
Okay. So the first numbers, at teenage, we had premature children as well as normal birth weight children. And we hypothesized that the premature children would have a lower quality of life score than the normal birth weight. And they did, in a way that you have a p-value of 0.02. But the scale is from 0, which is equivalent to dead, and 1 is perfect health. And can you imagine that the premature group, although is statistically lower, but they rated their quality of life mean score of 0.87. And this included the participants with disabilities, and 28% of the young people had disabilities. So despite that, the scores are fairly high. And this created such a sensation that we were in New York Times. And the New York Times took one of our patients who was blind, who was downhill skiing, and they tried to find out if this was really true. And Dr. Kempf from Oregon was totally unaccepting and could not believe that the quality of life was so high from their perspective. So then I repeated it at young adulthood because I thought that now they're no longer under the protective cocoon of their parents. And so despite the fact that we had higher scores the last time, I hypothesized that the quality of life would be lower in the premature group than the normal birth weight. And this time, the scores were no different. And again, it includes its participants who had disabilities. Next slide, please. So here you see a histogram, and the x-axis is the percentage, and the y-axis is the utility scores from 0 to 1.0. And the premature group are in pink, and the normal birth weight in blue. And you see that above 0.9 score, which is high, the majority of both premature and control group rated their quality of life above 0.9. But there's a lower end, it's a tail right down, both in prematures and in controls. So Dr. Kempf wrote an edit in the letters to the editor that he could not understand why the premature group rated their quality of life so high when so many had disabilities. And we replied and said, to us, it's more perplexing why the control group rate their life so much lower. They have no disabilities. So it's really interesting that maybe it's not the disabilities that create low quality of life, it's how you deal with it. Next slide, please. So the prevailing perception, most of the people say that a good quality of life is not possible if you have a disability. But if you take the perception of the individuals themselves, they're discordant with the objective measures that the health status professionals provide. So it is also well known that proxy respondents rate the quality of life of individuals lower than the individuals themselves. For example, if a person goes for renal dialysis, the parents and health professionals feel, poor guy, he comes 3 times a week for renal dialysis, his life must be really poor. But the person who has the renal problem says, it's okay to go 2 or 3 times a week, and I can live the rest of my life in a way that I wish. So we have also shown that health professionals rated the severely disabling health states among our patients much lower than the teenagers and their parents themselves. And more health professionals rated some of the very severely disabling conditions as worse than dead. Now, we are parents as well, so maybe we're looking at it a little more objectively, and we know a little more, we rate the quality of life lower, but the individuals living in that state don't rate their quality of life as low as we think. Next slide, please. So the Albert and Devlinger in 1999, that was 3 years after our teenage study was published, they did a study on Chicago, in Chicago, of individuals who were severely impaired, but not prematures. And they also reported that they had a good quality of life. So Albert and Devlinger said, why do so many people who have serious disabilities consider their quality of life good when to you and me, it looks as if their quality of life is totally undesirable? So they coined the word a disability paradox, and they said the high quality of life reported by some respondents could be due to secondary gain when they adapt and they reconstitute the meaning of their lives. But premature children have never known life differently, and they have adjusted much better because they really didn't know what it's like not to be impaired or to not have any issues. Next slide. And this young woman says that this is the only life I know and I'm happy. So investigators should look through the eyes of the beholdee, not then the beholder should look more carefully. Next slide, please. So they further questioned, why do so many individuals rate their life so high and appreciate in ways that we who are able-bodied may never be able to understand because of what they have achieved despite their limitations? Next slide, please. So that health professionals view quality of life and look at variables such as mental health, wealth, growth, blood pressure, cardiometabolic sequelae. And we now have considerable data on all these variables. But we have never taken the trouble to find out what premature children rate their quality of life and life satisfaction. What challenges do they face? So it is also naive to expect close correspondence between different responders. So we don't say that anyone is wrong, because health professionals can have their views, parents can have their views, and the children can have their views. So but the feelings of the group that we are assessing should be considered paramount, even though we may disagree with their perspective. Next slide, please. So we have too much data. Health professionals throw up their hands and say, we have 200 variables. What do we make of this? But the young people, they're very smart. They know how they feel, and they're quite able to project and talk about themselves. They have incredible introspection. Next slide. So, when they were 24 and even at teenagers, I would always ask some of them to give letters, which we put in the parents' room to give the parents something to look forward to. But when they were in their 30s, they wrote such beautiful letters that I just felt compelled that it should be shared, not only with our preemies parents, but parents all over. Next slide, please. So honestly, I'm embarrassed to say that I didn't know that a field of narrative medicine existed. And it's the effective practice of medicine related to acknowledging and absorbing and interpreting the stories and plights of others. And I believe they say it's a model for human and effective medical practice. Next slide, please. So, as Sabine has said, we published this book and also a video, which is 25 minutes long and it's worth seeing. Next slide, please. So, the book has 41 stories written by these preemie individuals in their 30s, and it's difficult to project all that. But what I did was I read and reread the stories, and I compiled a few themes. Now, this is content analysis, but it's without the theoretical framework of qualitative studies. So Sabine will appreciate that this is the lowest on the totem pole, but this was the only way I could talk to you. Next slide, please. So in terms of religious and other support, I did not ask the individuals what their religious affiliation was. Next slide, please. But this young woman, Michelle, her parents are Dutch Reform and very religious. And she opened her letter with the statement, infant voices, and she quotes Psalm 8, Lord, O Lord, your glorious name. So at the end of the letter, she writes, the bud that was my tiny life at the beginning has since grown to a fully bloomed flower. Be encouraged. And she was blind from birth, and she was working as an intervener for blind and deaf individuals. But later she herself became deaf due to recurrent ear infections. So she now uses the same services that she was offering. And she was absolutely amazing. Next slide, please. And Andrew, he says, although I grew up in a Christian home, he said he could not accept his disability and wondered why God had given this to him, until he said he met a pastor who said to him, Andrew, you're not disabled, but rather you're uniquely gifted. And he now helps other individuals with disabilities. Next slide, please. So also, like many of us, the people obviously would want to have support from marriage, partnership, and family, when fewer of them were married or cohabiting than the normal birth weight group. Next slide, please. So this young woman, who was one of our preemies, became a nurse. And she, and you may have read from our work and others that there's infertility is much higher, and prematurity rates are much higher among women who were born prematurely. So she had 3 preemies, and she works in a neonatal unit and looking after preemies. So she says she's been everywhere. The odds of a surviving prem, the nurse for premature babies, and the mom of preterms. Next slide. Kathleen is quite an intellectual. She did a PhD in Oxford on Shakespearean, in the Shakespearean Institute, on the androgyny of Shakespearean plays characters. And she said that because of all her work, she was stunted romantically, and she envied some of her friends. But then she also said, like all women do, is struggling with the academic career trajectory pressure to avoid having children and wanting to have children. Next slide, please. So anxiety, depression, and advocacy, the odds of mental health were 2 to 3 times higher in ELBW. And in our recent studies, autism is 10 times higher than in the control population. Next slide. So here, Michelle, who I just talked about, who is blind and deaf, she was married and later divorced, and she had bipolar affective disorder. And she said she tried to commit suicide several times. And she said she finally got the appropriate medication and she's stable now. And she says, I'm grateful to God that I did not succeed in killing myself. Again, she cites God. Next slide. And Rebecca Smith has autism. She's high functioning, and she participates in grand rounds and talks about her disability quite plainly, and says that the pain of mental illness is just as real as that of a physical disorder. So she fundraises and supports other people. Next slide, please. And Jennifer developed a severe social anxiety disorder, and she didn't go out of her house for a year. And then she started reading a lot, and then she started to be bold, and she she says education helped her immensely, and she decided to take trips to New York to just face her social anxiety right away. And apparently, she said she's gone 5 times to New York now. Next slide, please. And here's Kathleen again, and she also went through OCD, which she says she put to good use because of her studying for her PhD. And she went through clinical depression, anxiety, insomnia, and eating disorders, but she learned to cope with these. So it's amazing that these kids, they do learn to cope with all these disabilities and manage and still survive. Next slide. Next slide. So bullying is very sad. A lot of the preemies get bullied at school, as do children born at term if you're slightly different. And this young man, because he grew very tall, he was over 6 feet when he was in high school, he had some dark patches under his eyes, and he was called terrible names. And he said it further contributed to my social awkwardness. Next. April, she is just an unbelievable person. She has CP and it's mild, she's ambulatory, and she says it's a mixed blessing because when you have a severe disability, the kids leave you alone. But she says, I, on the other hand, was too close to normal and yet just far enough from it to be scary. And she says, she talks beautifully in the video, and I'm invited to a Gravens conference in Florida next month. And they have also invited her. So I'm sharing the limelight with her, and I'm so proud. Next. So I'll just show you this video, and I don't know if this will work, Sabine. You'll have to click at the bottom.
I don't think this will work because this is the, you send it with a Adobe document.
Oh no.
It's not
What a
the
shame.
PowerPoint.
What a shame. So sorry. It was beautiful video. Okay, next slide.
You want to try to share again? I don't know. Or maybe we don't
Well,
want to waste time. Right.
Just won't waste time. I'll see in the end if I can get mine to work.
Okay.
Oh,
That's probably
oh,
supposed to be the video. No, it's just black.
Yeah, but it's black. You can still click it.
No, it's because it's the Adobe. It doesn't. Nope.
Okay. Oh, so next slide, please. So this is Rebecca again, who has autism. And she says that despite my outward appearances, she's very petite. She says, I'm proud to be me. I wear my differences like a badge of courage. And she says, I won the battle and war against prematurity. And if these mild deficits are the price to pay for being alive, then I can live with them. And she calls this a mild deficit. Here's April again. No, that's okay. Next slide. And she says, I would not be the person I am today. And she says, it's not because of disability, but in spite of it. And she says, I may not be climbing mountains or winning Olympic medals, but she says, I'm not let cerebral palsy stop me from leading a full and independent life that she wanted. And she's a great writer. Next slide. Next slide. This young woman, I used to work in the neonatal unit with, and she was my patient, and she had hydrocephalus. And those days, we used to do ventricular taps, and we kept doing ventricular taps on her. And I always wondered what her life would be like. And later, she had a shunt. And the surgeon, neurosurgeon, Dr. Hollenberg, she came to the retirement party, and she spoke. And she says, when I was younger, I thought he was my hairdresser because every time I went to see him, she says, my hair had to be shaved. So she was quite amusing about this. Next slide, please. So blindness really affected me a lot. And in those days, this is the early neonatal era, that we had quite a few children with blindness. Unilateral or bilateral, 10% had blindness. And I used to wonder what their life would be like. Next. So here's Maurice. She's French Canadian, and she is bilingual. And she did a degree in linguistics and a degree in translation. And she worked in transcription for a while. And then she did a master's of education. And she helps individuals who are students with disabilities, the same resources that she says she used herself. And she sings in the choir. She even sang in a jazz concert at the Lincoln Center. And she bought her own condo. And the movie shows her moving around in the condo and how she types. It's actually very lovely, and maybe you can see it later. And she, when I was writing the book, she read the whole book and wrote a beautiful epilogue from her perspective, summing up all the other kids' reports. Next slide. Kim Harborough is another quite an intellectual woman who reads a lot, and she reads a lot of classics. And when I say read, it's audio. And she writes in her letter that the human brain is miraculous. It can adapt to the loss of sense that many people think, especially when one is young. She says a blind person's visual cortex becomes rewired and uses it for other purposes, such as interpreting certain sounds. So you probably know that blind people are very perceptive to sound, and that's how they relate. Next. Next. So she says, like the proverbial blind person, they all have an aptitude for music. And she studied piano, but she loves the flute, and she played the flute all the time. And music, she says, has a profound impact on my life. And she says to me one day, Dr. Saigal, I'm so glad I'm blind and not deaf, because if I was deaf, I would have died, she says very dramatically. And she also says many people ask her, if there was a miracle, would you want to see again? And she says, no, she says, I know a tree by hugging it. I know an apple by touching and smelling it. And I'm quite content to be blind, because if I become visually able to see, she says, I wouldn't be the same person. It wouldn't be me, she says. Next slide. So, Oliver Sacks, I'm a great admirer, and I'm sure many of you have read his work. And he wrote a lot on blindness. As you know, he also wrote on Parkinson's, and there was a movie made as well. And so he said, a person who had lost his vision, and as an adult, due to some surgery, he was able to see. And he says that you have to change your thinking from the experience forms of acquired by touch to the images that are now apparent to him by sight. So this blind person, he showed him an apple, a real apple, and a picture of an apple, and he couldn't distinguish between the two, and until he felt the apple. And he said these profound words, now that I have felt it, I can see. So there's also a movie based on his stories, and he's written a book about his life, a memoir, which is called On the Move, and it's just amazing. I'm a great admirer of Oliver Sacks. Next slide, please. And again, you'll miss this video. Next slide, please. So the only thing I asked these kids to do is to leave a message for future parents, but they were free to write whatever they wanted to. So they wrote beautiful letters, message to future parents. Next slide. And Elizabeth Abler, who has cerebral palsy and low cognition, and she's the daughter of two professors in Kitchener, and her language skills are amazing. But she's very brave. Now both her parents have died, and she's coping amazingly well. And she says to, I urge you not to give up. Like me, your baby is a fighter. Next slide. And Jennifer says that we learn to adapt to our issues, whether it's breathing, vision, motor skills, and which other people take for granted. But she says it isn't as hard or depressing as you may think. She says there's beauty in all this as long as we have our family, love, and support from family and friends. Next. And lastly, they themselves wrote about the gratitude and introspection. And none of them said, I wish I was dead. They all said, I'm glad my parents kept me alive. Next slide. And this young woman, Sarah Hill, says, she wrote her letter, a whole paragraph before she said, oh, I'm blind. And so she says that when she was born, her parents were told that I was a perfectly formed baby girl. She quotes that. And she said, they said that because they didn't think I would live very long. And of course, they were mistaken. And she says, I'm glad they were not correct. Next slide. And this is Amanda. She's a lawyer. And she says she's thrilled to be part of this important study. And she says, I so want the opportunity to give a little back to the hospital. And she makes little quilts for the babies in the neonatal unit. Next slide. And this young man says that he was born prematurely, and he says he has inability to connect with his early life. He says it's like waking up in a world where everyone else has experienced war except yourself, because he doesn't see any evidence of the aftermath. Others can connect with the memories and trauma and anxiety, he says, but all I see is the present and future. And he's a psychiatrist, and that's his introspection. He worked with me for a while in neonatal unit doing an elective, and I was hoping he would become a neonatologist, but he chose psychiatry. Next slide, please. And Breer says, the way I see each day is an adventure, each day is a blessing, each day is a gift, and there's only one answer to respond with awe and gratitude. Next slide. So until recently, as I said, this existential perspective of former preemies was missing. We never asked them, how has prematurity affected your life? And when we did, we were surprised at their positive responses. So how do we reconcile our pessimistic views with the views that they project? And I think their views are more important, and we should respect them. But still, despite all this information that's available now, the first study we did on the teens was published in 1996. And we, of course, started in the early 90s. So it's many, many decades that this has been going on. Yet many health professionals continue to consider such reports as unscientific and nebulous. And I was talking to Sabine before and saying that I had a little reluctance in admitting to this, being the author of this book, because of the views that many health professionals have, that it's non-academic. Next slide. So what are the lessons that we've learned from preemie voices? We see that despite their biological imperfections, that they're leading a rich and often satisfying life, that there's something called the resilience factor, and which of course is also helpful when you have support from your parents and other individuals. And scientific methods are now available to understand the personal life quality moving forward. So these personal perspectives that I have talked about and this quality of life that I've talked about can be complementary to the medical data. The medical data is very important, but also the personal perspectives of the individuals is more important, and it completes the picture of the individual. Next slide, please. So I would like to thank John Tyson, who supported me with this video, which you can see at your leisure. Next slide. And I have to acknowledge the immense gratitude I owe the preemies, their normal birth weight, and their parents for hanging around with me for several decades. And this work would not have been possible without the assistance of my mentors, colleagues, McMaster and APIC collaborators, research staff, and of course, the generous support of the funding agencies. Next slide. And I'll end with Allison's words. How do you say thank you for life when she has her own baby? She realizes and thanks. Thank you very much, all of you. I'm so sorry this has been chaotic. I hope you got something out of it.